My background is that I had an MD, Ph.D, and then I did residency and stayed on faculty at Johns Hopkins. I had a clinical focus and a research focus of prostate cancer and was involved in prostate cancer genomics for a while. Had integrated with molecular companies like Decipher early on and did some work with them in development. And it's been nice for me to see that come into my clinic. In my clinic, I routinely use molecular testing because it serves as a valuable adjunct to other clinical pathologic features in patient decision-making. And that's sort of the way I see most of the world going, to really do precision medicine for these patients. The role now mainly looks at, whenever someone's diagnosed with localized prostate cancer, the first decision is, do I have to treat at all, or can a period of surveillance be appropriate? And, from lots of different well-performed prospective kind of cohorts and also some randomized control data, there's men that can go all the way up to a favorable risk categorization that could be candidates for active surveillance. So that is one of the major wheelhouses for my low risk and my favorable intermediate risk disease to decide on surveillance or not. I think that genomics is a huge adjunct in that sphere. There's only about 10% of those patients that will have a high risk molecular score, but if they have a high risk molecular score, those patients act more like truly unfavorable intermediate risk patients in my mind. There's some nice work by Spratt and others that kind of suggest this. And I usually tell them, that 10% of the folks, that we should not think about a surveillance strategy. In the lower risk patients, and even in some very low risk patients, there is still a clinical question on surveillance, if you're going to put them towards surveillance, about how often do you have to monitor them by an invasive procedure like biopsy. In some of those patients, I do get some value from genomics up front because it will tell me how quickly that tumor is proliferating, or give me a sense of that, and so I can have so I can then make my ascertainments on when I want to do my next monitoring beyond PSA. So that's the favorable risk group. I would say, particularly as you get to the less favorable part of the favorable risk group, the genomics becomes more and more important. And then there's the emerging area, which is in the unfavorable intermediate or intermediate risks, high volume favorable intermediate, that you're going to treat, and questions about what you want to treat them with. And I think particularly it's been helpful for me when I make decisions around radiation for those patients. So if you take the favorable intermediate risk patient that you're going to treat with radiation, the next big question is, do you give that person a short course of androgen deprivation or not? This is an issue that the patients care deeply about. Most will recover their testosterone, but there's a lot of toxicity. There's a lot of data that the over-treatment rates of short-course ADT in favorable intermediate risk and even for some unfavorable intermediate risk may be very high. Here is somewhere where at least retrospective data with Decipher biopsy has indicated that if you're at the lower genomic risk, you may not need the androgen deprivation therapy to have excellent clinical outcomes. And that is a huge area of need in decision making, and it's an area where the data has been coming stronger and stronger. And on the flip side, if you're unfavorable intermediate risk and you have high genomic classifier scores, it might be a patient where you think about extending the therapy out a little bit longer. But again, it's an area of high research, but I think also an area where we already know enough to be using it in our clinical practice.